My name is Ashley Adkins. I am a registered nurse and I am a BSN student at Polk State College, and I'm currently in my final capstone course. And this video is just going to go over my professional portfolio. I chose the hard version of the professional portfolio versus an electronic version. I personally feel that a hard copy version is a little bit more personal. It allows a prospective employer to actually put a face with the name versus my resume or my portfolio just kind of getting lost in the electronic stack, so to say. So the first part of my professional portfolio is my resume. My resume is very simple and very concise. I was always taught to kind of keep a resume short and sweet. Basically, my objective is to obtain employment as a registered nurse to provide high quality and compassionate care. Then my resume goes on to list my experience. I've been a nurse for almost 4 years, and all of my experience has been at Lakeland Regional Health. I initially started on our trauma unit there, worked on the trauma unit for a little over 1.5 years, and then transferred up to the inpatient rehabilitation unit, better known as Banish. So then also my resume goes on to list my non-healthcare related experience. Prior to becoming a nurse, I was a paralegal for about 11 years. Then my resume lists my education, and then my certifications. So the next portion of my resume is the IHI certificates that I completed for this course. And the first one is the QI 101, Introduction to Healthcare Improvement. The second is the QI 102, How to Improve with the Model for Improvement. Third is QI 103, Testing and Measuring Changes with PDSA Cycles. And then QI 104, Interpreting Data, Run Charts, Control Charts, and Other Measurement Tools. And then QI 105, Leading Quality Improvement. So then the next portion of my portfolio mainly focuses on my PDSA project. So let me talk to you a little bit about my PDSA project. So my project took place on my current unit, the Banish Inpatient Rehabilitation Unit. And at Banish, we care for a very diverse patient population. We care for stroke patients, traumatic brain injuries, multi-traumas, orthopedic patients, spinal cord patients, cardiac patients, and then just sometimes overall debilitated patients, all with the goal of getting the patients home or back to the community setting. We do not want to send the patient to a facility. And at Banish, the patients undergo 3 hours of intense rehab a day with the therapist, and then also everything that they do back in their rooms is supposed to be therapeutic. So all of the nursing interactions, everything that they have with PCAs, or actually we call them rehab coaches, it's all supposed to be therapeutic. We are supposed to have the patients do for themselves, with us there as their teachers, basically. So we teach them how to do for themselves. And as a nurse, that can be kind of difficult because, you know, when I worked on trauma, I was so used to doing for my patients, and I still do for my patients, but sometimes it's harder to actually step back and allow them to do as much as they possibly can for themselves. So that's a little bit about Banish and what we do. But so my time on Banish, I've noticed one of the major challenges to our nursing staff is discharge planning. And our nurses are very, very involved in the discharge plan. We have an interdisciplinary team conference that's held daily, Monday through Friday, and that's attended by the nursing staff, the medical director, clinical manager, all of the therapists that are seeing the patients. Our neuropsychologist will be there, and then also our care coordinators they're basically social workers. And so during that team conference, we discuss, the patient's medical status, any discharge barriers to therapy, our goals for them, and just, how are they doing, basically. And during that team conference is also where we set our discharge dates. So the nurse's role in team conference is to bring up any type of foreseeable barriers to discharge. So, for example, if the patient is an insulin dependent diabetic and they were managing their injections at home, well, now this patient's had a stroke and it's affected their right side and their right side dominant. So now how are they going to administer their insulin injections? Or if a patient is now on a new high-cost medication, such as Eliquis. A lot of our patients are on Eliquis when they leave. So that's a very expensive medication. So how are they going to afford this medication? And this is all put on the nurses. Or, if we're currently doing intermittent straight caths on the patient, and they are requiring intermittent straight catheterization, can they do it themselves? I mean, a lot of patients can't. That sometimes, depending on body habitus and, all of that, there's a lot of patients that are unable to intermittent straight cath. So all of this should be brought up at team conference. And a lot of times this is not. Our nurses are so busy during the day, they kind of just get called into team conference and they're unprepared, or they're, unaware of the discharge barriers with their patients. And so then this creates major delays in discharges and major problems when we're trying to discharge the patients. Sometimes on the days of discharge, it's a colossal mess, basically, for the discharging nurse, because then she's trying to clean all of this up, or he or she actually. They're trying to clean all of this up. They're trying to figure out how am I going to get this patient home safely? So the goal of my project is to kind of clean this up a little bit. Try to prepare something or create a team conference planning tool that will assist our nurses in preparing for team conference, identifying the discharge barriers that will not only make them more comfortable in team conference and feel a little bit less overwhelmed, because it can be very overwhelming sometimes in team conference. And then also to affect our unit financially, as far as to reduce our length of stay a little bit, that will positively affect the financial reimbursement to the unit. So I prepared a team conference planning tool. The team conference planning tool has several sections to it. There's a section such as, one of the sections is continence, anticoagulation, DVT prophylaxis, diabetes, hypertension, skin and wound care, infection, nutrition, and then social. So, and then under each category, there's just information, such as, is the patient being intermittently catheterized, or the new medication orders and supply issues, that type of thing. The goal was to basically make team conference run a little bit smoother. So the initial test cycle occurred with just one nurse, and she agreed to use the team conference planning tool while preparing for and during team conference for one of her patients. And I got a little bit of feedback from her, and one of the major issues that she had with the team conference planning tool, although she found it to be very helpful, she said it was just very long. That, psychologically, when you look at it, you're just a little overwhelmed because it's 2 pages of information that you feel like you have to complete. And, if you're busy with 6 patients, it's, and 3 of those patients are scheduled for team conference that day, it's very hard to properly prepare, and this form was a little daunting. So I revised the team conference planning tool form to just one page. Sorry. And what I did is I took out some of the information regarding education and just made it a little shorter by changing the font size and all of that, so that whenever you take a look at it, you're not overwhelmed by just the team conference planning tool form, because I did not want that. So for my next cycle, I had all of the nurses that were included that particular day in team conference. There were 4, and they each used the team conference planning tool form for one of their patients. And the feedback that I received was overwhelmingly positive. Most of the nurses were very, very happy to use the team conference planning tool form. They found that it actually helped them plan and prepare for team conference. They felt a little bit more confident when they walked in. And so the hope is that the usage of the team conference planning tool form will eventually affect discharges, make our discharges go a little bit more smoothly, and then also affect length of stay. Now, of course, that's a long-term goal. So very happy that after the second cycle, I met with my manager, my clinical manager, and she was very excited about the results of the usage of the team conference planning tool form. And there's a possibility we may be rolling it out unit-wide. I'm not sure if we're actually going to make the usage of the form mandatory or just have it available, but just the fact that my PDSA project may actually lead to a meaningful change on my unit is just very exciting. So it's a very, very proud moment, I guess you would say. So anyways, as I come to the end of my BSN journey, just reflecting a little bit on it. It's been a very long journey. For me personally, the timing of getting my BSN was absolutely horrible. I recently welcomed a second child into my family, so it's been a very stressful and chaotic time, but I'm very proud. This is a very proud moment. My BSN it's led to some changes in my practice. I kind of look at my practice a little differently than what I did before. Prior to enrolling in the BSN program, I was just very task-oriented. I didn't, look at the big picture. It was more so just, I was focused on what I was doing for my patients, my orders, and that type of thing. But now the BSN program has led me to see the bigger picture in healthcare. Why do we do the things that we do? And it's just led me to see that I can even though I'm just one nurse on the floor, I can actually make a change in our practice for the better of our profession. So I'm very glad that I embarked on this journey.